So thank you very much. An extraordinary talk, a very illustrative clinical case. And by now, let's move on for another clinical scenario of patients with heart failure. But before, I need to highlight some important data about this problem, because we must remember that heart failure has become one of the main concerns in cardiovascular medicine today. And this is because the high prevalence, the poor prognosis, the elevated cost, and unfortunately, despite the new developing of therapeutic tools, in the real world, less than 50% of patients are optimally treated. And this is not only reserved for high developed countries. Indeed, in developing countries like Mexico, we observe that the prevalence of heart failure is very high. In our country, for example, we estimate that the prevalence of heart failure in adult population is more or less 2%, that it is equal to more than 1.5 million of Mexicans. So this is a very, very important public health problem. And by the other hand, on the good side, we testify in the recent years very, very important progress with regard to the treatment of patients, almost in the HFrEF patients. And by now, the use of 4 different drugs, that is ARNIs or ACE inhibitors, plus beta blockers, plus MRAs, and recently the addition of SGLT2 inhibitors must be considered the foundational therapy, and the early implementation is the new paradigm for the treatment of HFrEF patients and must be considered as the obvious. But despite the combination of this quadruplet therapy, the patients remain at high risk of several adverse outcomes, because we must remember that even the new heart failure guidelines recommend the early implementation of these 4 pillars for the treatment. The question is that it is enough in terms to modify completely the prognosis of patient. Well, we must remember that heart failure is a progressive disease, and each hospitalization is an urgent call for the treatment optimization, because in a patient with heart failure, the events of worsening are the beginning of the end for most of the cases. And I want to show you this clinical case. This is a 68 years old male patient with ischemic cardiomyopathy. Since 2021, he develops HFrEF with a left ventricular ejection fraction of 30, and he's chronically in functional class 2. And he had one hospitalization due to acute decompensated heart failure episode in the last 12 months. The pharmacological treatment of these patients includes sacubitril valsartan, carvedilol, spironolactone, empagliflozin, low doses of furosemide, and because he's an ischemic patient, obviously, he's under the use of atorvastatin and aspirin. And in September 2022, the patient suffered a new episode of acute heart failure secondary to dietary and pharmacological transgression. The last because he related fatigue and exercise intolerance with the drugs. And upon the arrival at the emergency room, the patient was found to have borderline blood pressure, tachycardia, gallop rhythm, jugular plethora, and severe peripheral edema, as you can see in the slide. The initial studies demonstrated cardiomegaly in the chest ray, the pulmonary congestion. The electrocardiogram shows sinus tachycardia, and the echo in the emergency room showed ventricular dilatation with generalized hypokinesia, and the LVF was estimated in 25%. The lab test showed us slight elevations in the urea and creatinine levels, and very, very important elevation of NT-proBNP, and the troponins were normal. And as you remember, the electrocardiogram didn't show changes on the ST segment, and therefore an acute systemic ischemic substrate was ruled out as a source of this worsening episode. So at this point, we have a patient with an acute episode of chronic heart failure decompensation in a wet and warm setting according with the guidelines. And for this reason, our patient received treatment with supplemental oxygen and intravenous diuretics. And additionally, we reduced the dose of sacubitril, valsartan, and beta blockers by 50% because borderline blood pressure and wheezing. Fortunately, the clinical evolution after the start of this in-hospital treatment was very good, with significant improvement in the dyspnea grade only 72 hours after the IV diuretic infusion, with important weight reductions and normalization of the urine output. The systolic blood pressure was normal, but the patient remains with high heart rate. The NT-proBNP was reduced 96 hours after admission, more than 50% since the baseline levels, and the renal function was normal. So at this point, we must remember the considerations for a safe discharge of patients. By now, the clinical guidelines states that a patient must be considered ready to discharge from a hospital when he is hemodynamically stable, euvolemic, and this is very important. The most important thing is that all the patients must receive the evidence-based oral medications before the discharge. And this is important for us. And 5 days after the hospital admission, our patient was considered fit to be discharged from the hospital. And at this point, we must remember the concept of the so-called vulnerable phase of heart failure, which runs from the episode of worsening until the following months after it, and represents a transition phase from acute heart failure to chronic heart failure, and is the most and represent the most risk for adverse outcomes. But by the other hand, the vulnerable phase represents the best window of opportunity in terms to optimize the treatment of the chronic phase patients. So the treatment at discharge considers sacubitril valsartan at low doses, carvedilol, spironolactone, and empagliflozin, and we decide at this moment start ivabradine. We reduce the furosemide dose and keep the statins and aspirin and program a follow-up visit in 1 week. And the question is, why ivabradine? Well, we must remember that heart rate, as Pedro said previously, is a powerful clinical variable with prognostic impact in patients with heart failure, especially during the vulnerable phase. And a slight elevation in heart rate on discharge predicts outcomes, including mortality. And by now, the evidence shows that for each 5 beats per minute of increase in heart rate, the risk of death increase very significantly. But unfortunately, in the real world, a high proportion of patients do not reach the goal of heart rate control. And this is more frequent, as you can see in the slide, in patients during an episode of worsening. And despite the fact that the beta blockers must be considered the first line of drugs in terms to control heart rate, more than 70% of patients do not reach an adequate heart rate control based only in a monotherapy with beta blockers. And why ivabradine? Well, ivabradine is a selective IF current inhibitor that has not a negative inotropic effects. Ivabradine doesn't affect the blood pressure. The evidence showed that the combinations with ivabradine with beta blockers improved the dose titration of beta blockers indeed. And ivabradine in the literature improved the quality of life and the risk of rehospitalization for worsening heart failure. And in these particularly frail patients, the hemodynamic effects of ivabradine have been shown that it's very, very well tolerated. But ivabradine is not only a safe drug. For example, in this post-hoc analysis of the SHIFT trial, ivabradine reduced significantly the risk of death by approximately 39% when we start at a heart rate of 75 beats per minute. And for all above, we decide to start ivabradine in early conjunction with the first-line therapy. At the follow-up, 1 week after the discharge, the patient was clinically stable in NYHA class 2 with only mild peripheral edema without lung congestion. The systolic blood pressure was stable, but as you can see, heart rate remains high. And for this reason, we decide to up-titrate the dose of ivabradine to 7.5 milligrams twice a day, and still remain the doses of the rest of medications. And the evidence showed that the early combination of ivabradine with beta blockers, particularly with carvedilol, leads that we can up-titrate to the optimal dose of beta blockers, and the effect on the control of heart rate is very, very good. But not only this kind of effect is observed. Indeed, studies like the ETHIC acute heart failure demonstrated that the early co-administration of beta blockers and ivabradine promote an important improvement in another outcomes like the improvement in left ventricular ejection fraction and a reduction of biomarkers of myocardial stress like BNP. And the follow-up 4 weeks after the discharge exhibit a clinically stable patient. The vital signs was stable, and we observed an important reduction of heart rate to 72 beats per minute. And at this moment, we decide up-titrate the carvedilol dose from 6.2 to 12 milligrams twice a day, and still the rest of medications at the same dose. And one question is if we consider the start of vericiguat. Well, this is a very good question because the results, for example, for studies like Victoria, but by now this drug is not available in our country. Finally, the 3 months after the acute episode, the patient returned for the program visit, and he was clinically stable. The 6-minute walking test was very good, with a distance of 380 meters. The clinimetric assessment using the Kansas City Cardiomyopathy Questionnaire was good, with a global score of 82. And the physical examination showed an optimal heart rate control with normal blood pressure values. And the lab test showed the minimum elevation of NT-proBNP, and by now our patient is free of worsening episodes. And for this reason, at this moment, we didn't make any other treatment adjustment. Finally, the question at this moment is how to achieve an early optimization of the management of heart failure. Well, one of the answers is the systematic use of the Optimized Heart Failure Care Program, which was designed by Professor Martin Cowie and by now is active in more than 40 countries around the world. The program considered the use of 2 simple tools that work as safety barriers and for patients and doctors to ensure work together and guarantee the optimal treatment in the shortest time after a worsening event. In our experience, as a part of this program, we demonstrate that the use of this kind of approach represents a very important opportunity in terms to optimize the treatment over the obvious. And by now, more than 90% of our patients in our program receive the optimal treatment, not only with the 4 foundational therapies, indeed with an comprehensive approach, including, of course, the use of ivabradine for heart rate control, and this represents a reduction, very important reduction, in the rate of readmissions in the short and midterm follow-up. Finally, we must remember that in the real world, we have many patient profiles, and we must to implement all the recommendations of the clinical guidelines as soon as possible. For this reason, our Mexican clinical guideline in heart failure recommend that the 4 foundational pillars must be implemented in a lapse no more than 4 weeks since the diagnosis. And the next step must be taken quickly. For example, with regard to heart rate control, if we do not reach the goal in the scenario of chronic ambulatory patients, we should not wait more than 4 weeks to decide the addition of drugs like ivabradine. And in the patient in the vulnerable phase, we must consider the early co-administration of ivabradine plus beta blockers in the early vulnerable phase. That is, since the hospitalization or no more than 1 month after the discharge. And we don't forget that the optimized treatment requires the use of non-pharmacological intervention, all the drugs, new, classic, adjuvant, and ongoing, the rational use of devices, and the implementation of interventional cardiology, electrophysiological procedures for adequate patients, and for some patients, the collaboration with cardiac surgery. At the end, we can conclude that heart failure must be considered for the treatment, that the real objective of us is not only control the symptoms, we must to improve the prognosis of this progressive disease. The new paradigm for the treatment of heart failure is a combination of 4 different classes of drugs. But in some cases, this is not enough. So we must walk beyond the obvious. And there are additional variables with prognostic implications, and heart rate is one of them. The heart rate control improved the result and must be considered as a therapy for many patients with heart failure. And more than half of patients during the vulnerable phase of heart failure doesn't exceed adequate control. For this reason, the early co-administration of ivabradine with beta blockers is a good strategy for the optimal heart rate control, even during this transition phase. And we must consider this administration in many patients who need an adequate heart rate. Finally, the optimized heart failure care program offers useful tools in terms to improve the therapeutic optimization in heart failure patients during the vulnerable phases. So thank you very much.